Retrograde EUS-guided ileocolostomy for malignant small bowel obstruction. Luminal and biliary obstructions are common challenges in patients with advanced gastrointestinal malignancies. This subset of patients is more prone to complications after surgery due to poor nutritional and functional status. Surgical interventions are also associated with longer recovery and interruption of cancer treatments. EUS-guided biliary and luminal interventions are being increasingly utilized in these settings. Various EUS-guided transmural techniques such as gastroenterostomy, enterocolostomy, decompression of afferent loop obstruction, and biliary and gallbladder drainages have been reported with good clinical outcomes despite challenging anatomies. EUS-guided interventions offer faster recovery and the ability to resume diet and cancer treatment sooner than surgery. Compared to percutaneous interventions, EUS-guided endoscopic interventions offer patients a better quality of life by resuming a regular diet and avoiding percutaneous tubes and drainages, in addition to requiring fewer interventions. We present a 64-year-old female with a history of pulmonary adenocarcinoma and a history of perforated goblet cell carcinoid tumor of the appendix. She underwent extensive cytoreductive surgery with heated intraperitoneal chemotherapy 5 years ago. She had a recent small bowel obstruction requiring expiratory laparotomy with extensive lysis of adhesions and resection of recurrent tumor. 4 months later, she presented with abdominal distension, nausea, and vomiting. CT showed evidence of distal small bowel obstruction. A nasogastric tube was placed for decompression. She was considered a poor candidate for further surgical interventions. After reviewing her CT, we noted good opposition between the rectum and a distended distal small bowel loop. After a multidisciplinary discussion, a decision was made to proceed with EUS-guided enterocolostomy using a lumina-posing metal stent. The patient received a prophylactic dose of antibiotics. The procedure was done under general anesthesia. The patient could not receive bowel preparation due to complete obstruction. An endoscope was advanced to the sigmoid colon. A wire was left in the colon as the endoscope was removed. While the airway was protected under general anesthesia, 1 liter of contrast mixed with saline and methylene blue was injected through the NG tube over a duration of 10 minutes to distend the distal ileum. A linear echoendoscope was advanced to the sigmoid colon, guided by the wire, and then withdrawn slowly. At the rectosigmoid junction, a distended small bowel loop was identified on endoscopic ultrasound and fluoroscopy. Given the opposition of this small bowel loop to the rectosigmoid junction, this loop is identified as a distal ileal loop. This loop was opposed to the colon with no intervening organs or blood vessels. An electrocautery-enhanced lumina-posing metal stent with a diameter of 15 mm and a saddle of 10 mm was deployed, connecting the colon to the ileum proximal to the obstruction. Methylene blue was seen flowing from the stent after deployment. The stent was dilated to 15 mm. There were no adverse events after the procedure. Postoperative CT confirmed a successful enterocolostomy with complete decompression of the small bowel. Her diet was advanced to a soft diet, and she was discharged home under hospice care. She had no recurrence of small bowel obstruction until she died 3 months later. Conclusions: EUS-guided interventions to treat luminal and biliary obstructions in patients with advanced gastrointestinal malignancies offer faster recovery and a better quality of life compared with surgical and percutaneous interventions, respectively. Retrograde EUS-guided ileocolostomy appears to be an effective palliative tool in selected patients with advanced malignancies presenting with small bowel obstruction. Additional studies are required to determine the safety and effectiveness of this technique.